Welcome to the Interstitial Cystitis Association's Spring into Summer event, an interview with Dr. Lenore Ackerman from UCLA Health, who will be talking about her latest IC research on trying to understand how different pain generators may influence individual treatment needs. Special thanks to Desert Harvest, who has sponsored today's event. At this time, I will turn it over to Desert Harvest CEO, Heather Florio.
Hi, thank you, Lee. Thank you for having me. This was very important to us here at Desert Harvest to be able to bring Dr. Ackerman's research to the forefront. So without any ado, let me introduce Dr. Lenore Ackerman. For those that don't know her, she is a doctor at UCLA. She is the Director of Research for the Division of Female Pelvic Medicine and Reconstructive Surgery. And she specializes in treatment of women with incontinence, voiding dysfunction, and pelvic floor disorders. Thank you for joining us today, Dr. Ackerman.
Thank you so much. It's a pleasure to be here.
So let's just jump right into it. So one of the biggest questions we get is about nomenclature in regards to interstitial cystitis. We have urologic chronic pelvic pain syndrome. We have interstitial cystitis. We have bladder pain syndrome. And no one knows which term to use, and they interchange, and even the clinicians interchange. So can you really define those terms for me and how they should be being used?
I would love to, but that's a really, really big challenge, and it's a really tough question. I think that there was initially a movement to utilize the term, the UCPPS term, which stands for urologic chronic pelvic pain syndromes, to be more inclusive of anybody who might have either some kind of combination of pelvic pain and urologic manifestations like urinary urgency and frequency. The term has really not gained a lot of traction, so you don't find it being commonly used in your average, practice in the community. And so the terminology of interstitial cystitis and bladder pain syndrome tends to be the more commonly used terminology, but we really don't have a great definition for it. In general, we tend to utilize that term to relate to anybody who has some form of pain in the pelvis that they perceive of being related to the bladder. And that's about as good as we get as a definition. There are many more types of definition systems that are used in different organizations across the world, and none of us can agree. I was recently part of a panel trying to do a better job of coming up with this terminology. It was an international panel of experts from all over the world. And basically, in the end, we couldn't decide what that consensus terminology would be. And so when I talk about patients, I tend to just say that, if they perceive they have bladder pain, I say that they have bladder pain and call it a day with that. And until we have a better consensus about our terminology, I think we're really going to be impaired at advancing this field. And so that remains one of our biggest, I think one of my biggest, and one of the sort of academic world's biggest challenges and goals for the near future.
Yeah, I think I can remember in the 90s where we were using interstitial cystitis here, and in Europe they were using bladder pain syndrome, and it just became, which one should we use? Which one should we use?
Right. And I think it's hard because, especially from the patient perspective, to not know what information to be looking at and how to be moving forward. I think, it seems a very simple debate, but it's been sort of really a critical problem at defining how we conduct our studies and which patient populations we include. So at the moment, there's really only two sort of, we sort of categorize all patients under this umbrella, and have only really had one thing that we can really sort of refine as a diagnosis, and that's this concept of Hunner's lesions or ulcerative disease. And that's something we can confirm visually on cystoscopy, that if we see lesions within the bladder that are, again, there are still some differences in how we define them, but inflammatory lesions within the bladder that are either frank ulcers or regions of very clear inflammation with bleeding, that's something we can say, hey, we see this, we can call this ulcerative disease in one form or another, whether you call it ulcerative IC or you use the ESIC criteria from the European organizations or whatever, and then a bladder that's much more normal appearing and has bladder pain, and that we sort of can put into a different sort of category. But other than that, we really don't have a lot of terminology that we can all kind of agree on across the world.
Yeah, a lot of people in the groups term it the hunter's ulcers too, or a hunter's lesions, or and what percentage of interstitial cystitis bladder patients actually have the ulcerative lesions?
So again, unfortunately, it probably depends on how you define those ulcers and who you ask.
Mm-hmm.
In a practice like mine, I probably have an incidence of about 25% of my patients may have ulcers. Mm-hmm. But I am, working at a tertiary referral center where I see sort of an enrichment in patients that probably have a higher probability of having those ulcers. So likely in the community, in a regular sort of urologic practice, it's probably much lower, around, I would guess, about 10%. Those numbers are a little bit conjecture. In the literature, it's been reported anywhere from, say, 5 to as high as 60%. And I think that really depends on the people that you're looking at to begin with. But in general, it's definitely a smaller fraction of our total patients who have bladder pain. And those ulcers are definitely enriched in older patients. And so it's a lot less likely to find those ulcers in younger patients. Not impossible, but much less likely.
Okay. And then tell us a little bit. So you were recently part of a study that was published in November 2021, looking at phenotyping bladder pain. Can you tell us a little bit more about that, about the makeup of the study?
Absolutely. So this study really originated from a frustration I think we've kind of already explored a little bit, but it's definitely a frustration I have on my daily basis in the clinic, which is that we don't really have a very customized approach for patients who come in with pelvic pain, whether they describe it as bladder pain or pelvic pain or discomfort or burning or whatever those symptoms are. We tend to kind of have a one size fits all approach, or actually just kind of a like choose your own adventure, which I'm not sure how helpful that is. If anybody remembers choose your own adventures from when they were kids, but I sense when patients come to see me how frustrated they are. And I have to say, I'm pretty frustrated too. I don't feel like I do that great a job at managing patients' pain. And I don't really have a lot of guidance on how to do a better job. But one thing that I think I observe, and that I know a lot of my colleagues also observe, is that even though patients come in saying, my bladder doesn't feel right, it burns, it hurts, it doesn't feel good, there are sort of other patterns that are associated with that primary symptom that are really quite different between different groups of patients. And so this study originated really, as several other studies have done as well, but in the idea that we treat everybody the same, but probably there's a lot of different types of pain, or a lot of different types of patterns in the pain that people have that really are quite different from person to person. And we really shouldn't be treating everybody who comes in exactly the same way. I have a colleague who I think describes it a lot like cough, right? If our primary doctor, when you went in, just took every patient that came in with a cough and just treated them exactly the same, it's kind of intuitive that would probably do a pretty bad job of taking care of people's coughs. Sometimes it's an allergy, sometimes it's really a cold, sometimes it's a flu, sometimes it's an irritant or something that you're inhaling. There's lots and lots of different reasons why people can have a cough. So why would we think about treating all those exactly the same way? So this study, we really began to try to do a better job of understanding what are those different patterns in patients' symptoms when they come in. And one of the reasons we chose to do it the way that we did, which was to use what's called machine learning, was to try to take out some of our assumptions as clinicians about those patterns and just let the data tell us what the data had to tell us. And so that's what we set out to do, was to use something called machine learning, and ask the data to tell us what do patients look like if we take out all of those assumptions. And so that's where we started, was just with that idea of saying, hey, let's try to figure out better what those different patterns are, and to do it in a way that's not shaded by my assumptions or perspectives on pain.
Personalize the approach using the machine learning to create
exactly.
optimization. I love it. Okay. And so so in this, how many participants were in this study? How were they chosen? What kind of average age?
Sure. So we took basically anybody who came into our clinic complaining of bladder specific pain. So they told us their bladder hurt. That was sort of the primary inclusion criteria, was just saying, somebody came in and said, I feel like my bladder hurts. And in the end, we ended up with about 145 patients overall who met that criteria. And there's one other thing that we did do, which was important to the results, which was that we only took premenopausal women who were under age 45. So both of those things had to be true. They had to be premenopausal and be under that age cap. And so the average age of our patients was about 32. That was important to us, because when people have tried this before, it has been challenging to really identify easy or clear groups of patients with pain. And one of the things that some of our early research before this study found was that older patients, especially as you approach the menopausal transition, have a lot of other stuff going on. So the incidence of overactive bladder and the urologic symptoms that are accompanied by overactive bladder rises precipitously. And also you have what's called genitourinary syndrome of menopause, which can often manifest with urogenital pain as well, and urologic symptoms. And so we kind of wanted to pull those things out of the analysis and really focus in on what we could learn about just bladder specific pain. And so we decided to focus on this premenopausal population of younger women to get as clear a picture, at least a starting point. And the point was not to exclude those older patients eventually, or to exclude men, which are both excluded in this study. It was really to get a starting place of saying, if we can get a population that's as homogeneous as we can get, which obviously isn't very homogeneous, but as much as we can we start to see some patterns? And then we'll go back to those other populations, hopefully in further studies, to try to do those things translate into this population, if we can do a better job of defining them. So that was how we started. Younger patients, really with just isolated, with who are describing isolated bladder pain, and get a look at that group of patients.
I love that, because so much of previous research didn't have that exclusion to that group, which I think, as you mentioned, could definitely skew the results. So that is wonderful. So what were the most prevalent comorbidities, prevalent conditions that existed in the patients, besides a diagnosis of bladder pain?
Absolutely. So because this was a younger group of patients, we tended not to see sort of those metabolic diseases like diabetes and high blood pressure, high cholesterol. This was actually a relatively healthy population, and most of the comorbidities that we saw in terms of just other things that existed, that patients, and this was self-reported, by the way, it wasn't diagnosed by me or by anybody else. We asked them what they had as comorbidities, and patients told us that a decent number of patients had anxiety as sort of a complaint of theirs, and sort of coming in just slightly behind that were things like irritable bowel syndrome and depression. And those things were sort of the biggest things. There were some other pain disorders, if you will, that were found at much lower frequencies, things like endometriosis or chronic migraines, things like that. We didn't exclude patients if they had those things. I think that's a pretty common thing that many patients can also have. And so we wanted to make sure it was representative of the kind of patients that we're seeing.
Okay. And then in the study, you broke the patients up into 3 unique cluster groups. What were these groups, and kind of what led you as a team to kind of divide them into these clusters?
That's great. So that's really the crux of the study was the groupings. And so to come back to that idea of machine learning, we used an approach that's called unsupervised clustering. And so in unsupervised clustering, you basically present the data to some kind of learning algorithm, and you can give it some input or not, and that's where the unsupervised comes in. And we basically just said, do what you will to the computer, trying to put people into different groups. And there are ways of sort of figuring out what are the optimal numbers of groups just based on how similar different people are. And so we asked the computer, how many groups do you think there should be? And it actually was sort of a choice between, say, 2, 3, or maybe 4 groups, so somewhere in that range. And we looked at the solutions for the 2 and the 4, and they didn't make as much clinical sense, I would say, as the 3, which is where we ended up. And so we just asked the computer to put patients into these 3 groups, and then looked at what those groups were. And so in this case, we're not making any judgments about who's in which group and what those groups are. We just asked the computer, and they spit out some 3 groups, and then we looked at the different patterns of symptoms in those 3 groups. And there were some pretty recognizable differences in that one group very much had very high scores on a couple of questions that talked about pain with bladder filling that got better as you emptied your bladder. And so that was sort of one group, and we called that the bladder specific or a pain group, or you could call it like voiding related pain or filling related pain or something like that, but it was definitely related to the voiding cycle. There was a second group that had a couple of features that really localized their pain slightly differently than the first group, which really put their pain right at the urethra and distal vagina. So there was this sense of pain that was kind of more urethral in origin. It was kind of more at the opening of and it was still related to the bladder. It was still perceived as being related to the bladder, but there's just this much more intense focus of pain kind of on the urethra. And then the third group had lots and lots of pain, lots and lots of bother, but they had a lot more urinary symptoms that seemed to be similar to the kinds of things that we see with what people would generally classify as myofascial dysfunction. So this feeling of like not being able to empty the bladder, and the feeling like even when you've just emptied the bladder, you still feel full, and that did not relieve your symptoms, right? It didn't, unlike the first group where if you peed, you'd feel better for some window of time, and that was when you felt your best. This group kind of felt bad no matter whether they just urinated or not. And it was always this discomfort and this pressure and this sense of not being able to empty that was pretty consistent, no matter how full or empty your bladder really was. And that group we called our myofascial dysfunction group, or our myofascial pelvic pain group. And that was not something we got out of the computer. The computer just told us these patients seem to look like each other. These patients just seem to look like each other. We really, at that point, took these different categories and went back to those patients, their descriptions of their pain, and started to look a little bit more into those qualitative descriptions that they gave us. Mm-hmm. And then said, okay, well, what are the common features? And we looked at their exams, and we looked at the different things we found on their exams, and it really seemed to also co-localize with exam features, even though that had not been part of the categorization system to begin with. And in that myofascial group, we found a lot of myofascial trigger points and pain that was really related to the muscular structures of the pelvis. Mm-hmm. In the middle group, there was a lot more of this distal, vaginal, urethral pain. And in the bladder specific pain group, or that voiding related pain group, there was a lot more like if you poke the bladder hurt. If you put pressure on the bladder in the suprapubic area, the bladder itself was really tender. And so those exam features and the different patterns of symptoms coming out of what the patients were describing led us to give those groups each their different sort of identities. And it's interesting because then when I initially when our little research team brought this back to our clinical division and presented this before we had put all the manuscript together, and that, it was really interesting. One of my colleagues looked at me and goes, "Oh, that's really fascinating. It jives so much with how I've just thought about this before." And I was like, okay, that's great, because what we really wanted was something that didn't just we wanted the data to tell us, but it's all that much more exciting and reaffirming when you hear back, oh, that makes so much sense with what I observed. So we wanted it to be clinically significant, but we didn't want it to be biased from the beginning by our assumptions. And it seemed like those two things both kind of made sense to people when we put the data together.
So is it clear to say that so the first group is really bladder focused? The pain was really localized and very focused to the bladder. Secondary, is that one more of like a neuralgia, kind of nerve more centered kind of pain?
I think so. I think that's where some of our studies really need to move forward at this point, because I don't know whether because it's not really a pudendal neuralgia, right? Like it's not a like when you we double check on that for that on all of our exam, at least I do, and those patients really were excluded from this. It has that same quality of just being sort of like this burning and irritation of the urethra, but I don't know where it comes from. And that's really where our next step has to be. That group in particular is really hard to manage, meaning I don't think we have a lot that's very successful at treating that type of pain. It's, I think, the most challenging. And we're starting to try sort of the approaches one might anticipate if it was more of a neuralgia, as well as some approaches that might be more topical or local sensitivity, like rawness or inflammation of that area, as well as some things that are more, maybe there's some muscle groups that we're not identifying on that deeper exam. So I don't know what it's coming from, but it's different. And by far that group needs the most work in terms of understanding what is it really and why is it so hard to make better. But I will just take one step back and say, yes, it is more like a neuralgia, but if you ask the patients what hurts, they'll tell you, absolutely, my bladder hurts, and they'll point to it, and so I think that's part of the difficulty, is the,
differentiation of that area. We have
right. And I don't know whether that's, that our terminology, like as humans, we don't have a lot of great discrimination of what is bladder, vagina, urethra, uterus, rectum even. There isn't, we're not wired to do a lot of distinguishing between those different things. We just know something down there doesn't feel right. And so I think that was the idea, was can we just see the patterns to help in the questionnaires, so that you don't have to be a magical genius who can differentiate a small amount of urethral neuralgia or I don't know what from some other thing on exam. Can we provide at providers at all levels, even at the primary care setting, a tool that they could use that doesn't require incredible skills on discriminate pelvic exam to be able to start to make some progress in identifying some of these different clusters. And again, with the rise of telemedicine, I think this is going to be more important than ever to give that tool that doesn't require a detailed pelvic exam.
To figure that out, or a cystoscopy, or
exactly, or that kind of exactly.
And so that third group, in that myofascial muscular pain, you what did it say? 80% kind of saw a resolution with pelvic floor physical therapy, correct?
Absolutely. And so that was the other part, was that we did notice that when we kind of put these patients into different groups, our original study was not designed to really assess treatment responses, but since we were looking back and trying to figure out what those features were, we were able to sort of see the courses of those patients over time and see if the kinds of stuff that we typically prescribe, which are things like physical therapy or bladder installations or things, systemic medications like amitriptyline, which of these things was working for which of the different patients. And really found that for that myofascial group, a lot of them got substantially better with pelvic floor physical therapy. It was really helpful. And that's actually pretty similar in terms of overall improvements with the IC literature in general, that physical therapy tends to be the most successful. But I think the thing that was funny was that it didn't work as well on the other groups. And so when you pull out that group that has a lot of features of myofascial pain, that if you can steer them to physical therapy really early, that hopefully you can make a big difference. And that's something that will have to be borne out by further studies. But again, that group seemed to very distinctly respond well to that kind of therapy.
Wonderful. And then they can overlap, correct? So you could have all three, you could be in all three groups.
Yeah. So that's this is again very early kind of data that we're trying to develop further, but the computer took everybody and dropped you in a bin, and whichever bin you ended up in was sort of where most of your symptoms made sense. So the people who are in one group tended to look like or have similar features to the other people in that group. And so the way that I tend to think about that is that if your dominant feature was that pain with filling as your bladder got more full and was relieved by bladder emptying, you ended up in that group. What we then did was we took each of those groups and we kind of looked at those really defining features, which we kind of have gone through already. But if you take those defining features and then you look at the other groups to see, do any of those patients have those sort of hallmark features as well, you can totally see substantial overlap in those symptoms. And the most overlap is definitely in that myofascial group, or that myofascial feature. Maybe that's the best way to put it, that symptom of myofascial, sort of dysfunction. Again, coming back to that idea we discussed a minute ago of that feeling of your bladder just always being uncomfortable and always feeling this pressure and this fullness, like you need to go, but then you go and there's nothing there. And if you take that feature and you look at the other two groups, it's pretty commonly there. And so I think that while some people can have that as their really dominant feature, and those people seem to do very well with pelvic floor physical therapy, that feature can be present in those other groups as well. And so our hypothesis from that is that each of these types of pain is sort of its own thing. So you can have that voiding related pain, you can have myofascial pain, you can have that urethral neuralgia pain. And each of those things is kind of separate, and they can exist all in the same person. They can be, only one can exist in a person, or they can have 2 out of 3. And what we found is that only about a third of patients, when you looked at it from that perspective of like just has this one feature, so only about a third of patients really only had one of those features. Now maybe that they had a dominant feature, but the other 2/3 seem to exhibit sort of signs of more than one of these things, which brings me back to, why do we do such a bad job of taking care of patients? And I think part of it may be that either we're only addressing one symptom at a time, or that sort of one size fits all kind of approach. And that what patients may really need, what people may really need, is to say, oh, you really have this kind of pain and this kind of pain, and we need to target your treatment to make sure we're addressing all of that. And there's definitely good data in other types of pain, like fibromyalgia or even chronic migraine, that sort of, especially myofascial pain, that hypertonicity that can happen in muscle groups when people have chronic pain from something else can perpetuate the original pain. And if you can't break that cycle somewhere along the way, if you address one or you address the other, you never make progress, because one reinforces the other and then drives the first to get worse again. And so I think part of that is how I've come back to thinking about this. And again, that data is not in this paper. Yes. That's just kind of my own.
Well, yes, it's interesting. I mean, we constantly hear, I had a back injury, or I had, this happened to me. I was in a car accident and I got IC, and so it's a constant story that we hear, that an injury precipitated, them being diagnosed.
And it's possible that that's causing some sort of neurologic dysfunction that's then driving that one kind of pain that drives myofascial pain, which, and I don't think we understand any of this well yet, but I think to me, it made me take a step back and say, hey, nothing is that simple. There are features that I think we can pull out and sort of think about, different types of ways of addressing that pain. And that's hopefully going to be the next step. And that's what we're trying to work on right now, is to say, hey, can we do a better job if we use some of these features to assign treatments? Do we do a better job than if we just try one size fits all with everybody? But part of that is going to be not just treating it as one single type of pain per person. Like, I think people are more complicated than that. And these pain types can sort of interplay between each other.
That's wonderful. Yeah, understanding the complexity of the person individually. Kudos to you for.
Well, it's not really a new concept. This is really stuff that has come out of the wonderful pioneering work of people like Chris Payne, of people like Dan Shotsky's and Curtis Nickel. A lot of these systems have been proposed previously, and I think when used right, they actually are really quite effective. I think the limitation of some of those systems is they're just hard. They're hard to do. It's not that they're challenging, but they're just time-wise challenging. And the way medicine is structured these days, most providers don't have it in their schedule to be able to spend 4 to 5 minutes doing this, very detailed symptomatic assessment and a pelvic floor exam and everything else that they need to do to figure all of that out. So I think one of the things we were hoping for is to try to get a computer-based algorithm. If we could just ask patients, hey, tell us about your symptoms. maybe we can get a starting point to work on that in putting people into sort of these, or at least rate, how bad is your myofascial domain, and how bad is your bladder specific pain domain, and how bad is your, urethral vaginal pain domain. And then we can kind of give each person a personalized output. God, that would be my dream for where we could go with this. Because then again, you don't need to have that, you don't have to find, an hour in that one person in the whole region that maybe can do that for you. We could broaden the ability of providers to have a starting point to work from.
Yeah, a questionnaire that maybe they could answer before they even get to their visit. That
right.
Formulated into the algorithm so that when they actually get down to see their doctor, they have a starting point to work with. They have data and information. I love it. That would be
someday. We're working on it.
And I think that probably you've really gone into my next question is kind of the future of this, the future of subtyping, the future of being able to find these distinct phenotyping in each single person that would then lead them down the proper roads for the proper treatments.
Absolutely. No, I think that, so I did sort of, that was my dream for like someday in the future. I think the biggest thing as next steps is really to, figure out the right number of groups, or what those groups are that has the most clinical significance. And what I mean by that is, we started to try to look into this with this initial study of saying, who cares what the date? There is a point where you kind of got to step back and say, I don't really care what the computer says if that doesn't translate to making sense in the clinic. And so that's why we were happy with this, is that so many of my colleagues looked at the data and was like, oh, that's kind of how I think of it. It makes sense to me. But does it really make sense? And can we show that sort of in a larger population? Or I think the biggest way to handle this is actually in more prospective studies, is to actually say, could we use treatment outcomes as our gold standard and say, okay, patients who respond to physical therapy have these features rather than the other way around? Because that may make more sense. And that's a much harder, much longer study. Going to need some, funding for that one. But I think that to me is, how do we all decide what categorization system, what terminology makes the most sense? Well, I think the way to do that is to show that there's a clinical impact to some of those choices. And to me, since we don't currently have biomarkers, we don't currently have any tests that we can do that really do that for us, the best thing I think we can hope for is that we can say who gets better with what. And if we can say, this group of patients gets better with this, then let's look back at those patients and say, do they all have some common features that maybe we could predict? Or that gives us a better way to start looking at the concept of biomarkers or diagnostic tests, is to say this group is clinically different because they get better with X, Y, or Z. And then if we can use that to define what that group really is, then maybe we can do a better job not only of identifying those patients, but really here's what I think is the important frontier, is trying to figure out what works for them better than what we currently have, right? And so many of our studies have just been torpedoed, I think, if that's an okay word to use, by the fact that not everybody's the same, And so if our groups divided pretty evenly amongst those, maybe one group, the myofascial was a little bit larger than the bladder specific pain, which was a little bit larger than the urethral vaginal pain group. But there were plenty of patients who fit our inclusion criteria who were differentially sort of spaced across those groups. And even if you had 100% of one of those groups responding to a treatment, your overall study, if you don't do any sort of picking and choosing of who you include, is at best going to be 35%. And that's if everybody in one group got better. And so I think for us to think of better therapies that pharmaceutical companies are going to want to spend the money on to bring it to market, we have to be able to get better than that. We have to do better than that. And I think that's where the next frontier is to be able to do a better job of identifying some of these different phenotypes and do whatever those phenotypes are. Maybe they're not mine, maybe they're not the ones that came out of previous studies, but whatever those are, to be able to identify meaningful subgroups of patients so that we can get them better therapies and identify who's going to respond better than we're currently doing. So I think that's really our long-term frontier.
That's been definitely our struggle at Desert Harvest, and even with our clinical research is with the Desert Harvest super strength aloe vera capsules. We know that 87.5% responded in our double-blind placebo-controlled study. We know that that data carries along from the 29 years that we've been doing it, but we know that now that IC has really become so much of a diagnosis of exclusion, we've seen more and more rates of misdiagnosis, and then it goes, how do we know how we get that group that we know is going to be able to respond? And in that mind, it goes to the idea of the bladder-centric people for us.
Right. No, I think you're probably exactly right. And I think that's what we observed in the study, was that these therapies that are designed at release soothing the bladder, whether that's a bladder analgesic or a bladder installation or aloe vera or dietary changes, that those things really focused in that one specific group. But it's really hard to ask companies, hey, field a trial where you power it. You have to power it to see that subpopulation, but you can't identify them from the outset. And I think that's been the big problem, is that it's, we can talk about the costs of research and development and why those are kind of going to be high, but in the end, it's very difficult if you have to do a study that's 4 times larger than you would otherwise have just to do it, just to be able to identify those patients who would respond. And we're just not seeing companies rise up to doing that. And
that's the problem. One of the things, we are a small family company, so we try to put as much as we can into research, and ultimately we're partnering with Wake Forest. And so I think we'll have to talk a little bit more about how we could utilize some of your research in that. Our hope is to get multi-center and get up to 600 patients, because start with the initial Wake Forest, subset, and then be able to branch out to there, because then we can find those distinguishing features. We're going to be looking at specific distinguishing features in this. We're going to be doing a series of blood work, a whole series of things, and then we're going to kind of try to add into that study we've been doing a study at McGill University with actually our CBD, interestingly enough, which will be debuting at FENS, the neuroscience conference in Paris later this year. We're really excited because the research has been astounding, but just from a neuralgia perspective, but that goes strictly to neuralgia. Like, we studied myofascial pain, we studied all of these in the group that responded. Like the bladder centric pain was like an 83% reduction in 24 hours. And that goes more to the neuralgia than it does to the specific to, the overall makeup of the bladder and the urothelial lining and everything else like that. So it'll be interesting as your research evolves, and so many other people are doing research that we'll be able to change things. We'll be able to change how they diagnose, how they treat, and it won't be this necessarily one size fits all that so many people are lumped into, and try this and see where we get. And we'll know that we could send the myofascial group right to pelvic floor physical therapy, and they're going to do amazing. So
no, absolutely. I think that's the future. I hope that we can do better. And I think those are the things that will do it. And I think once we've kind of gotten a better sense of what those groups are, maybe then we can start to actually develop real tests. If we can understand where this comes from, right? That's really the holy grail, is to understand the etiology of each of these. How does it start? How does it perpetuate? Meaning, it isn't just a matter of starting, but it has to sort of start and then be maintained. Like, why does it not get better? And so when we have a better sense of what those things are, maybe we can develop better diagnostic tests. Maybe we can better develop targeted therapies that are really addressing those underlying causes why these start in the first place. And I think one of those things that overlap between groups, the way that different types of pain can perpetuate other pain, is part of why it gets so confusing, is because everybody almost everybody has some myofascial pain. Like if you've got pain in a region, there's this natural tendency for the muscles in that area, wherever it hurts, to kind of guard a little bit. They're tightening, they're tensing to sort of try to protect that area. And so it's, you're going to find that in almost everybody, but
any woman that gave birth.
Absolutely. And to identify when that's a bystander to when that's the primary driving force is really tough. And I think that's where some of our system tried to do that. But I think until we can do a better job of finding out what was the underlying thing driving it to begin with, it'll be really hard for us to do a good job, at least, of developing new therapies that are aimed at addressing and possibly resolving, right? Like, wouldn't cure be great? But how do you resolve something that you just still can't even define what it is,
Yeah, and it, at least grouping will individualize that maybe you can get to the root cause of the bladder centric, and understand that would be, utopian.
That's the someday we can keep.
Yeah, someday
keep working for that.
We'll get there, because I know that most IC patients, when they come to us, every story is different, and we get to hear, so many of our customers mean so much to us, because they'll call and ask for a specific person. They'll call and tell us about stories about their birthdays and get grandkids, but the most thing we get to hear is their story about how they came to get their diagnosis. And so to hear that over the past 29 years, I can't say that there's a correlation in a distinct feature in that with anybody necessarily. Some can, say, oh, my mom had it, I think it's or I had the car accident, or, so many different reasons, or I had, this other comorbidity, I have fibromyalgia, and then it led to, and then I got diagnosed with IC, and so many different things that be really amazing when we get there and understand we need to dump all of that into a machine.
Yeah, no, I mean, that is the power of more data, right? The more we have, and the more we keep looking, the more that things like these algorithms can actually learn from that and do a better job with it. And when you think about the fact that we actually didn't have that much data, we had 5 questionnaires that comprised about 42 questions, which is really, and a lot of them are highly redundant. And so it's really actually not that much data. And considering, what could we do if we had even more? So I think there's still so much to do, so much to be learned. And hopefully, that's both, we still are at the very beginning, so there's still a daunting task ahead, but it also should be very encouraging that I think that there is so much more we can do.
Yeah, definitely. Well, thank you so much, Dr. Ackerman, for joining us, for sharing all of your amazing research and where you're headed.
Thank you so much for giving me the chance to talk about this, and I'm hopeful for the future, and that's for all that we can do. Thank you so much for letting me share.
Thanks.